Hi, my name is Randy Hecht, and I am a medical oncologist at UCLA. And I'm really fortunate to be asked by the Neuroendocrine Cancer Foundation to help run this session. And the title of the session is What Matters Most in Making Decisions About Systemic Therapies in Sequencing Treatments. I'm very lucky to have three other panelists who represent not just medical oncology, but other specialties as well from around the country. So they're going to go ahead and introduce themselves. Dr. Gangi,
Hi, my name is Alex Gangi. I'm a surgical oncologist, and I'm at Cedars-Sinai in Los Angeles.
Dr. Mitra,
Hi, everyone. I'm Dr. Erik Mittra. I'm a nuclear medicine physician at Oregon Health and Science University in Portland.
Dr. Zhen,
Hi, I'm David Zhen. I'm a GI medical oncologist here at the Fred Hutch and specialize in neuroendocrine tumors and I'm the co-director of the neuroendocrine program here.
one of the good things about the treatment of neuroendocrine tumors, particularly in the modern era, is that we have an awful lot of different options. What we don't have necessarily are many trials comparing one option to the other. And so part of what we're going to talk about today is how we put all this together. So there is no one size fits all for patients with neuroendocrine tumors. And in fact, there are many, many different types of situations where patients with neuroendocrine tumors and interact with their physicians. And so what I decided to do today was present some cases. And not only are we going to discuss these cases and see different physicians' viewpoints, but also we may alter the cases so that we can see how those alterations may change what you want to do. So if it's okay with the team, I'm going to go ahead and present a hypothetical, but definitely drawn from real life case. A patient comes to see me. She's a 53-year-old female. She has had chronic intermittent abdominal pain for a number of years with really out any ability for it to be diagnosed. She eventually has cross-sectional imaging and is found to have a mesenteric mass and multiple liver metastases. She has a normal liver function test. Biopsy of the liver shows a well-differentiated neuroendocrine tumor with a Ki-67 of 1%. She then undergoes further testing with a dotatate scan, which shows only the mesenteric mass as well as multiple liver metastases. And so the first thing question is, at that point, what would you do if the patient comes? I'm going to ask Dr. Zen to start out with, because patient may come to see you first or, Dr. Ganji. But let's start with Dr. Zen. What would you do at this point for this patient?
Yeah, obviously, with this patient, it seems that there, is evidence of stage 4 cancer with, metastases to the liver. With that said, I think, one of the things I would appreciate from Dr. Ganji's standpoint, it sounds like this patient is pretty symptomatic from the primary mass and be worried about potential risk of bowel obstruction. So even though we could discuss starting some systemic therapies, I probably would want a referral from the surgery to see if resecting the mass would be of help to prevent a future bowel obstruction, but then also even with the liver metastases, if there's any role to even optimally debulk the liver metastases there.
This is also where a multidisciplinary, conference or tumor board is really particularly useful because it's critical to have our surgical colleagues as well as our radiologic pathology colleagues all to sort of, bring this in. So even though often the patient may start with one physician, though some institutions have, multidisciplinary clinics where everyone's all in one place, is that if they start with one physician, there are many physicians who are involved. Dr. Kenji?
Yeah, so I think as Dr. Zen mentioned, it sounds like this patient has a symptomatic small bowel primary. I think one other thing that would be important for us in her surgical evaluation would be to evaluate the number and location of her liver metastases, because certainly I think from the perspective of the small bowel lesion in the mesenteric mass, resection would be indicated secondary to symptoms. The possibility of doing that would be dependent on where the bulk of the disease is with respect to the nodes along the mesentery and how it's involving essentially the SMA, which is the main arterial pedicle that supplies a majority of the blood flow to the small intestine. So we kind of gauge our ability to resect that based on where a bulk of that mass is in the mesentery. And then simultaneously, we would look for the primary tumor, which it sounds like wasn't evident necessarily on the dotatate scan. And sometimes we talk to patients about the fact that those could be very, very small, even the size of a sesame seed. So it requires some manual palpation to identify that lesion. And in 30-40% of patients, there can certainly be more than one lesion. So the goal would be to remove that mesenteric mass along with the associated small intestine. Certainly in scenarios when we're already in there, if the liver is debulkable, meaning if we can take out at least 70% of the disease in the liver, there is some evidence that that improves outcomes for patients in terms of hormone overproduction and could slow down the propagation of additional metastases developing over time. But that would be, again, entirely dependent on how many and where. So does that, I think, answer the question, I hope?
I think so. And I think it is really important. And of course, you probably would also take out the gallbladder as well in sort of anticipation of systemic therapy. Dr. Mittra, do you have any thoughts about, we sort of put dotatate scans together. Any other imaging thoughts about one type of dotatate scan versus another?
Yeah, thanks for that. So I was, as a nuclear medicine physician, glad that you mentioned dotatate PET right up front because, that is definitely the most sensitive way to kind of evaluate these tumors and also gives some information right away in terms of potential therapies related to the somatostatin receptors as well, which could be something that we talk about in the future. Although I completely agree, so far with what the others have said about the evaluation and in particular the surgical approach. At first, I would add from the imaging side that while dotatate PET is so critical these days, it is also very important to get conventional anatomical imaging, good quality as well. And probably Dr. Gangi would agree with that from the surgical approach too. So to get multi-phase CT of the abdomen and pelvis to kind of fully evaluate that would be necessary. As far as the different types of dotatate PET, my comment there would actually be that they're all quite good as long as your PET scanners are optimized for whichever isotope that you're using and you have a good availability of it. They're all very good agents.
Amazingly, I saw someone for the first time in a long time this past week who actually had an Octria scan, the old fashioned, and I guess those are still out there in the wild.
Wow.
The other thing, I think that's a really good point because only certain places actually do combined PET CT, and I think it's really important if you're trying to do local therapies versus systemic therapies. But frequently, I know Cedars does combined, UCLA does combined. I assume your institutions also do combined, but often we see people without IV contrast. I think that's something that's actually very good to discuss. This hypothetical patient did not have any significant hormonal symptoms. So we'll talk about that, later when we talk about systemic therapies. And so let's say that the patient is able to have liver resection of, say, all of the disease, as well as we have a dedicated surgeon who's able to get down to the root of the mesentery and remove all the primary. The question comes up then if someone has a complete resection, even including of liver metastases, is there any role for systemic therapy at that time? Dr. Zhen?
Yeah, so I think that's a fantastic question. And, there's a lot of variability in practice there. I think one of the things we always want to remember is kind of what is the goal of giving the systemic therapy, right? So in this patient who had a complete resection, I think our goal is there any therapies that could try to eliminate any microscopic disease with the goal of trying to increase the chance of keeping it away? And I think at this point in time, I don't think we have any clear systemic therapies or clear data to suggest that that's the case. However, I would allude to there is a national ongoing clinical trial being led by the NCI, SWOG S2104, which is focusing mainly in pancreatic neuroendocrine tumors with the premise that pancreatic neuroendocrine tumors often are a little bit more sensitive to chemotherapy. And so this trial is randomizing to patients who have higher risk pancreatic neuroendocrine tumors, so higher risk of recurrence, and randomizing them to either surveillance, which is our current standard of care, versus 4 months of capecitabine and temozolomide, or also known as CAPE-10. So
I'm really glad that you brought that up, though you have actually stolen a little bit of my thunder for my next case, which is a pancreas case. But I think that you did bring up something that is important with systemic therapy is that not all neuroendocrine tumors are not the same, and there clearly are differences in responses to various systemic therapies between small bowel versus pancreatic neuroendocrine tumors. And I think particularly for low-grade tumors, I think that what you just said, that the response to chemotherapy really is a difference. I think as you get higher, I think small bowel is more likely to respond to sort of the standard chemotherapies, though most people don't really necessarily end up with those. So afterwards, I agree that, the systemic therapy that might be reasonable after our surgical colleagues have done a complete resection could include observation and, in following the patient. Though I can't say that it's wrong to treat, but I can't say necessarily that it's right. Now, hypothetically, let's say our surgical oncologist was able to debulk but still left disease, or that on the dotatate, to change the scenario slightly, our dotatate scan, instead of just showing liver only, also showed lymph nodes as well as bone metastases. And I have to say, one of the real changes with switching to dotatate scans were the very large number of asymptomatic bony metastases that we see in patients with neuroendocrine tumor, though most of them, don't cause problems. So let's say that Dr. Zhen, that the patient went to surgery, whether they had debulking or not. However, on the dotatate scan preoperatively had extra significant unresectable extrahepatic disease. With a Cas67 of 1%, what would you do next?
Yeah, it's a great question. And these, I think, require both a multidisciplinary discussion, but also a discussion very closely with the patient about what their goals are. Because I think, Dr. Hecht, you alluded to the fact that one, obviously, we could start a systemic therapy, and I think many of us might consider a somatostatin analog. The goal there being, obviously, if a patient has functional symptoms, we want to try to suppress the hormone production quality of life. I think that's pretty clear if that was that scenario. But then the other, in a patient functional or not, whether we want to try to delay the disease progression, right? Trying to keep the tumor control for as long as possible. But also, I will say that if a patient has a low-grade neuroendocrine tumor, like in this case, sometimes these tumors just might stay stable on their own. And if we've removed most of the disease, that might not cause a problem for a while. So I think the other option would be to offer the potential for surveillance too.
And actually, I agree with that. The biggest problem was fixed by the surgeon, which was the sort of intermittent obstruction from the primary and the mesenteric scarring and around that. So let's say that the same patient who has extrahepatic disease, you watch them, and after a period of time, 6 months, a year, unfortunately, on either cross-sectional imaging, which means CT, or MRI, that's the term of art that we use, or on a dotatate scan. And I don't know how it is in north of California and Washington, but it's not so easy to get actually a dotatate scan because of insurance, particularly if you didn't start with disease that can only be seen on a dotatate scan. But let's say after a while, this patient has some progression. So you would start presumably with a somatostatin analog. Do you think there's any difference between them from an anti-cancer standpoint?
Yeah, I agree that most of us would likely consider starting somatostatin analogs given the tolerability profile. And, we have two main injections, either octreotide LAR, also known as sandostatin, or lanreotide. And, at least from my perspective, and at least from the data, I don't think there's any major difference except in terms of the administration of the two. So obviously with the octreotide LAR, longer needle, lanreotide, a little bit shorter needle, comes in a prepackaged syringe and stuff. So oftentimes my patients do prefer lanreotide, but many times insurance here at least will reject lanreotide and will often do octreotide. But from that standpoint, I think they're both equally.
We've actually moved mostly to lanreotide, at least for now, though that may change because of lower copays for patients. And they're just to mention, because patients are very interested in this, is that, well, as I always say, that the treatment is literally a pain in the butt. It's generally really well tolerated. And while people can have pancreatic enzyme insufficiency, diarrhea, some fatigue, in general, it's really well tolerated. And patients often ask about this. On the horizon, there is potential for versions of somatostatin analogs that block that signal, or actually the signal to grow, that are analogs of this turn-off signal. That's a better way of saying it. That maybe be able to inject it themselves at home.
Right.
And oral actually agents are approved in other indications, though I don't know whether they will be available anytime soon for patients like the one that we just discussed. Okay, so the patient is, doing well, does not have any significant side effects from the treatment, is going about doing what they usually do. However, and it can be years, if you look at the randomized trials that looked at both octreotide as well as lanreotide, that it can be years before the tumor gets worse, but eventually that the tumor gets worse. If the majority of the progression is in the liver, I know there have been other discussions about liver-directed therapies. And however, let's assume in this case that there's sort of progression everywhere. So the person has had first-line somatostatin analog, now has progression, does not have significant hormonal problems. What would you consider next? I know that you're usually the person who's involved often at this point. What do you think about second-line therapy?
Yeah, I think, the nice thing about neuroendocrine tumors is that we have a menu of different options. But the difficult part and when we're counseling patients is when we have a menu of options based on the current data, it's hard to say if one is truly superior than the other, right? So I think there's ongoing studies to hopefully answer sequencing kind of questions. But from my standpoint, I think the therapies that I often consider, at least for this low grade kind of small bowel and primary, I would often consider PRRT with lutetium-177 dotatate or Lutathera. We do have systemic therapies, like everolimus and now even cabozantinib. But I think the difference here, why I often might consider Lutathera is number one, it's an IV dose, 4 doses. There's logistical things, but it's a 4 dose and you're done versus coming
Right,
with the
fire and
other oral
forget to a
therapies.
certain
Yep.
extent.
It's a
Yeah.
continuous treatment and the ongoing
Uh,
side effects related to that. So, yeah.
Dr. Mitra, what would you say about that?
No, totally agree. I mean, that's exactly the scenario that PRRT or Lutathera was approved for, is patients with lower and intermediate grade tumors that have progressed with SSAs. Just a couple of comments on the imaging side is that I think at that point, especially as you're saying, oftentimes it can be years that, from the baseline imaging. And so it's important to repeat a dotatate PET scan to reconfirm somatostatin expression and also to ensure, kind of restage the disease as well and to see what areas are currently involved. For instance, you mentioned the liver dominant disease that patients sometimes have, which is well captured on CT or MRI, but those can often miss some of the extrahepatic disease, especially in the bones that you refer to. So it's important to repeat a dotatate PET. And the other quick comment about imaging with relation to follow-up and progression is, again, that's super important to get high quality multi-phase CT or MRI scans. It's so often the case that we'll see patients in that scenario that they've been treated, with the initial agents for X number of time, but they don't have good baseline imaging. And so it's really hard to then actually compare, what's been going on. And so that, I can't really stress that enough. It's so important to have good conventional imaging and periodic PET scans, ideally.
Virtually all those patients will actually have somatostatin receptor that you can see. And so my question is that how often do you see loss? I mean, we think about resistance, and yet, my understanding is that the vast majority of patients who are on a somatostatin analog, when they progress, still remain positive on the dotatate scan. In someone in the second line setting where we've seen loss. But so I would just say that I think it's worth doing. And if you want a good baseline to compare with, but I think it's not very common to, am I correct in that?
No, that's a good point. It's relative to the Ki-67. So the lower it is, the more likely it will retain the somatostatin expression, and the higher it is, the converse to that. But also, we know that certain patients do have some heterogeneity, and not everyone's the same. So that's why I sort of do advocate at least periodically to get a PET scan, and at least our practice is that just prior to initiating PRRT, we do like to get a new baseline at that time.
And this is something that's actually come up, and maybe it's not necessarily for this. When do you check again? Since we're talking about sequencing, the vast majority of people have at least stable disease. Major responses are not that common, in the teens, but most people don't need a major response. They just need their tumor not to grow. And I think occasionally people need tumors to shrink, but neuroendocrine tumor patients mostly need it not to grow because they're otherwise doing, really well. When do you check a set of scans after someone who's had standard PRRT, which just for the patients who are on, which
Yeah.
is the radioactive somatostatin analog, which has been discussed earlier today?
Yeah, great question. Because again, there's a lot of controversy around that, and related to that is insurance issues that you also alluded to previously. But our practice, and I think what a lot of places would do, is at least to repeat the conventional imaging again after the completion of PRRT at some point, approximately 3 or 4 months later. We also do try to get a PET scan as well, but it is very true that context of that is a little bit hard to evaluate, and there aren't good response criteria for a follow-up PET scan to know really what to do that with that information. So we do advocate mostly for conventional imaging, but if possible, to also get a dotatate PET.
So I think Dr. Zhen actually brought up some really interesting points about how we sequence. So the questions are, one, what does the patient want? And how much do they want to be there? We're all at major academic centers, but patients don't always live within walking distance of major academic medical centers and often come from far away to get expert care. So that also means that something where if someone has to come frequently for either follow up for an oral medication, or let's say we talked earlier about chemotherapy, being able to do something that's only for and then done is attractive. The other thing I think that's really important is what are the endpoints that we care about? And the endpoints we care about are overall survival, how long the patient has to live, which can be many years, and as well as quality of life. Now, the sequencing trials that have been done, the problem is, and this is a good problem, it's often really difficult to look at overall survival because patients do so well and people retire sometimes before they come off the trial. And so, Dr. Zhen, you had mentioned about trials comparing one versus the other. But for example, the recent, COMPETE trial, which looked at a progression-free survival endpoint, it seemed to look like PRRT was better than everolimus, which is an mTOR inhibitor, which is approved. However, the question that comes up is that, first of all, if you could, for our audience, explain what progression-free survival is. And the next thing is, and my question to you is, how important an endpoint is that?
Yeah. That's a
Hmm.
great question. So
Hmm.
progression-free survival essentially is our, oncology terminology we use in studies to demonstrate how long does a therapy is able to keep a cancer or tumor under control, right? And I think the definition of how we define tumor control is usually based on imaging. And there's also very specific criteria in terms of what we determine as growth, what we determine as stability, and what we determine as shrinkage, right? Which sometimes those bars are very different than neuroendocrine tumors compared to what we may see with other cancers, right? And what I mean by that is, I think if we're hoping for shrinkage, a lot of times many of our treatments don't provide a lot of shrinkage. But just like what you said, Dr. Hecht, is that shrinkage doesn't always is very meaningful, right, in this disease, right, as well too, right? And so I think progression-free survival, I think, is meaningful to an extent in terms of that if we can keep a disease under control for a long period of time, that's great. But also, I think we still have to take into account some of the other treatment side effects, the logistics and stuff. So even if something may look a little bit better, we're still measuring time, as you mentioned, sometimes on order of years, right? So even if something may be a little bit better or maybe a little bit worse, we're also talking about something that when we talk about sequencing, we're not necessarily meaning that if we do one X first, it might mean that the patient lives a shorter period of time, right? The time might still be overall the same, but then
Right. So the eventual destination, basically is the same, whether it's one
exactly.
versus the other.
Yeah.
And one of the things I always think about is, and I think you had brought this up, is the ongoing toxicity.
Hmm.
Particularly as medical oncologists, we give medicines that have ongoing toxicity.
Yeah.
Unlike our surgical colleagues who are in and then they do something for our patient, our nuclear medicine colleagues who treat a certain number of times, but our medicines do have, even somatostatin analogs can have some toxicity. So let us say that the patient has PRRT and does well, this hypothetical patient, and often, as you pointed out, can be for years. Our hypothetical patient does not have any hormonal symptoms. Hormonal symptoms actually make it easier to continue the somatostatin analog. Another question about sequencing is how do you feel about continuing the somatostatin analog after PRRT?
Yeah, that's a great question.
Hmm.
A very common question on referrals as well too. And I think, I think that's also an area where we have little data about what best to do. And I think there's a lot of personal preference in terms of what we do. From my perspective, I think if we were to follow the data for a patient who doesn't have any hormonal symptoms, I think it's very questionable about whether we want to continue the injections. At the same token, too, I also have patients who come to me and they say, well, what if there's some cells that are still being controlled by the therapy and I'm tolerating the therapy well and I don't mind continuing to get injections every month? There, I also, won't necessarily disagree if they want to continue, but yes, yeah.
I mean, there are, there are toxicities, not to
Yeah,
mention potential financial toxicity, because we know how,
correct.
eye-wateringly expensive these agents can be, though the patient themselves may not necessarily be paying for
Mhm.
it, which is appropriate and good. So let's say that our hypothetical patient has PRRT, then does well for 2.5 years, and then continues to be asymptomatic, as many of our patients are. Though there's certainly other things that can happen after surgery. Once it just reminds me that sometimes patients can have diarrhea for non-hormonal reasons after surgery, particularly after removing the end of the small intestine as part of that. But the patient's doing well and now has had good, stable disease, as most patients do, and has now progressed. Dr. Zhen, can you say what the systemic options would be at this point for this patient who started out with low-grade neuroendocrine tumor? And then I'm going to ask Dr. Mittra what he thinks.
Yeah. So I think number one, obviously, is just with any cancer, if there's any clinical trials that are ongoing, we always try to find those options,
Thank you.
right? But in terms of standard therapies that we would have here, right? And this is where I think we alluded to this earlier, the site kind of does matter, right? So for example, small intestinal neuroendocrine tumors generally have less response to chemotherapy. Not to say that we don't use it, but generally have a less response, especially for lower grade. So I think in this scenario, I think the systemic therapies that would be reasonable would be either everolimus, that would be one option, but also we have cabozantinib, which is a now new oral targeted agent that we have that was based on the positive results of the cabinet study. So it's nice that we also have a new FDA approved option too.
Though both of those agents, how do you choose between the two of them? Both of them have different sort of toxicity profiles.
That's
And,
correct.
and the patient who comes in to see you may be different. How would you choose between one versus the other?
Yeah, I think this is where the toxicity profiles are very important, explaining to that patient and helping to make a choice. Number one is always activity. Do we have any data that suggests that it might provide more robust shrinkage if I need to achieve that in a particular patient? I think overall, based on the results, it's not that much different. We're talking about response rates about 5% or so. So here, the toxicities I think are more important, and here it's kind of what is the patient willing to tolerate, right? So with the everolimus and such like that, the risk for potential mucositis, the potential for diarrhea, the potential risk for lipid issues, glucose issues and stuff like that. But then cabozantinib has its own side effects with the diarrhea, right, and blood pressure issues, right? So I explain that to patients and see what they tolerate, but also taking into account what symptoms are they actually having, right? Am I also willing to take that risk of seeing some of those symptoms worsen as well too? So
I think it's also important for patients to realize is that none of these are set in stone.
correct.
So this is the art of what we do, is that if you start with something, you can always switch to something else. And then, as I always tell my patients, the doses we start with are guesstimates. It's what a large group of patients were able to tolerate, but that doesn't mean that that's necessarily the dose that you have to have. And we adjust. So I think it's really important for patients to realize if they do have side effects, doesn't mean those drugs might not help
Correct.
them. Thank you again for bringing up trials. I have to say that we really are in a new era of trials for neuroendocrine tumors. And so for so long, it was really considered a disease or a condition where it was impossible to do studies. And because there just weren't enough patients out there and there wasn't enough interest. And we know because of advocacy groups, so like the Neuroendocrine Cancer Foundation, as well as the realization at the national level from our cooperative groups, as well as the pharmaceutical industry, that these patients deserve and need additional options, over and above what we've just been talking about. But I do think it's important to put people on study as a physician. And I think as a patient, it's important to consider clinical trials. So back to Dr. Mitchell. So what do you think about additional PRT in our hypothetical patient? So the patient is still asymptomatic. They have good preserved liver function, has had a good, I would say, stable response for a long period of time, that progression-free survival that Dr. Zhen was talking about, doing well. How do you feel about salvage PRRT?
Yeah, it's definitely something to consider in this scenario. The way we sort of think about it is if the patient has had a really good response to the initial round of PRT, and by that we sort of define it's a little bit vague, but most people define it as at least 12 months, if not 16 months of a stable disease. If that's the case, and again, a repeat dotatate scan still shows good somatostatin receptor expression, and as you mentioned, labs are all in order, then that's exactly the scenario where we would consider repeat PRRT. There's a couple of caveats to that. However, one is that it's not entirely known how many additional cycles are appropriate. Many studies were done with 2 cycles, but there are other studies that do, complete repeat of 4 cycles. We actually at our institution are using patient-specific dosimetry to try to help determine that to some extent. Another thing is that there is a lack of good prospective clinical data on this at this point. However, there's a lot of retrospective data that does support doing this. So, and then the third is there could be some insurance issues related to that, which I think is, as we know, with a lot of things is very regional. In our area in the US, we haven't really had any issues with it, but it could be something that comes
Yeah,
up in
we
some
have
other
not.
areas.
And
Yeah,
also, I know there have also been previous talks at this meeting about
yeah.
sort of the next generation of PRRT. So I'm not going to go with that. Instead, I'm going to focus on what we can do now. Are there patients that you would not consider that the medical term is contraindications, or patients that you're more concerned about not doing salvage PRRT?
Yeah, a few different things come to mind. One is the initial stable period of disease, as I mentioned. If that's less than 12 months, then we wouldn't consider it. If there's been a change in the somatostatin receptor expression, we wouldn't consider it. Also, if there's been a change in potentially how quickly the tumors are progressing over time, then perhaps some of the other therapies that Dr. Zhen mentioned might be more appropriate in that scenario as well. So those are kind of the main ones that come to mind.
One thing that has been brought up is that, some patients with neuroendocrine tumors, we had talked about the scars, but can also have peritoneal disease. And so that means that disease, neuroendocrine tumor that's growing along the bowels, even though it may not be necessarily easy to see. Sometimes those patients have obstructions and need to see our surgical oncologist. But I know that it's also been brought up that there may be some interaction between PRRT and small bowel obstructions, meaning blockage from that. Do you have any thoughts? Would that change how you would treat a patient?
Yeah, that's another area which is a
Mhm.
little bit controversial. There's anecdotal data that PRRT can exacerbate that. It's thought that the inflammation from the radiation may cause some of that small bowel obstruction. However, there isn't really necessarily strong data to support that as well. So what a lot of places have started doing is prophylactically to use some sort of steroids. There's a variety of different regimens that can be used in conjunction with the PRRT to sort of ward that off from happening. So that's one thing that people do think about. I personally don't think it's a contraindication myself, but it's something to keep in mind for patients.
Okay, so let's say then that our patient went ahead and had salvage PRT because they didn't want to come and see the medical oncologist as often. Even patients who benefit, it may not be quite as long. And hopefully by that time, since we started, remember that these things add up, and we're now talking years and years. My hope is that we have newer agents, but let's say that the agents that we have, so patient, then you could start on everolimus or cabozantinib. To be honest, as I said, other than the patient characteristics, I don't feel really strongly, one way or the other. Let's say that it's continued to grow. Would you consider rebiopsying at that time, Dr. Zen? Now we're several years out. We're probably 4 or 5 years out. Patient has had salvage PRT, cabozantinib, and or everolimus. Is that a time that one would consider rebiopsying? Because it started out with a Ki-67 in this hypothetical patient of 1%.
Yeah. So I do think if there's a really significant change in the behavior, both based on imaging, if there's like a more rapid growth than what I normally would have anticipated for a low-grade neuroendocrine tumor, and also the symptomatology of the patient that's like just seems a lot sicker than what normally has been the course, then yeah, I think the concern that's being raised is whether there might be some grade transformation, meaning the cancer, the neuroendocrine tumors evolved into a higher grade neuroendocrine tumor or even a neuroendocrine carcinoma that might affect our treatment decisions as well. So yes, I definitely would consider a biopsy.
So Dr. Gangi, what if, one of the things we always talk about to a certain extent in oncology are resistant clones, where most of the time things go in one direction, but sometimes one lesion is growing differently than another. Do you want to comment on potential surgical resection in that setting?
Yeah, I think surgery always kind of remains part of the toolkit that we have in management of these patients. And I didn't mention earlier, in a patient who presents with liver metastases, and it sounds like there were numerous, it's very common, greater than 80% likelihood that they're going to have some kind of in-liver recurrence, if not in other locations within a 5-year window based on all of the data that we have. So I don't think repeat surgery is ever necessarily off the table. It's just that we have to reevaluate the other options that we might have. And so in the scenario that you presented, it was a patient who was progressing throughout, right? Systemic progression. And so they were
Slowly.
PRT, right? Slowly. But then ultimately, if we're at a steady state with all of the other disease and there's one area that's progressing more rapidly, then it's not uncommon for us, if we're able to go in and essentially cyto reduce the patient yet again and try to, with the target of that one particular area being the main focus. And certainly if there's anything additional that we can debulk, we would certainly consider doing it.
And then finally, we were really talking about initially someone with a small bowel neuroendocrine tumor or small intestine for the patients. What if this instead had been a pancreatic neuroendocrine tumor? I had sort of a separate scenario, but let's just assume that it's similar and starting out as low grade. Dr. Zhen, can you comment then on, standard, what we call cytotoxic chemotherapy? And this, you mentioned it earlier, but if you could just, sort of elucidate a little bit more if this had hypothetically been a pancreatic neuroendocrine tumor.
Yeah, I think if this had been a pancreatic neuroendocrine tumor, whether low grade or high grade, we know based on studies that the site matters here. So pancreatic neuroendocrine tumors generally have more sensitivity to oral chemotherapy agents, here specifically referring to a combination of an oral chemotherapy pill called capecitabine and another oral chemotherapy pill called temozolomide. We call it CAPTEM for short. And this has been around based on a very large study that was done several years ago that demonstrated that not only does it help with disease control, but it even has pretty significant chances of tumor shrinkage, right? And I think this opens up the pathways in some scenarios, for example, where if for some reason surgery was not an option or was going to be very difficult, and the patient was very symptomatic, having a lot of pain and such like that, we actually have a treatment option in this setting where CAPTEM could actually provide a significant shrinkage and might even have a significant quality of life benefit in addition to the tumor.
And that actually brings up the question of what our goals are. If someone has widespread metastatic disease, shrinking it, unless it's causing a local problem, may not be as important. Do you have any problems about patients who are on capecitabine and temozolomide, what we call alkylating agents, who have also received PRRT? Because one of the feared side effects, though rare, PRRT are blood problems, either myelodysplastic syndrome or very rarely leukemia. Does that change at all how you feel about sequencing?
Yeah, so I think just like many other things, we kind of still have very limited data or understanding. I think we know there's an association that in patients who've been exposed to prior alkylating agents like temozolomide and then let's say get PRRT, I think there might be a higher risk of that myelodysplastic syndrome or MDS and leukemia. But I think one of the tough parts is that while we know that association, it's not a guaranteed association, right? And I think one of the tough parts when you're having patients in front of you, making sure that we're also not avoiding potentially effective therapies for a risk that could happen, but might not necessarily happen too.
And I think that once again is that taking care of patients with neuroendocrine tumors is a team sport. And that I feel that at least at some point in the treatment of these patients, that they should be evaluated in some sort of multidisciplinary form. And I think probably when there is worsening of the disease, that's a very good time to go ahead and reassess that. So just to finish up, I'd like to thank actually the Neuroendocrine Cancer Foundation, because one of the things that one of the many things that they do is also help with patient education. So by watching this and the other talks on this as part of this meeting, is that you become a better patient. And I think you should always feel free to echo what Dr. Gangi said. It's really important to ask your physician, why are they doing this? Why one thing versus another? Have a list of questions. And to be honest, if they can't answer your questions, then you should find someone who can answer your questions. So with that, I'd really like to thank you for your attention and for the panel for actually really this wonderful session.